Welcome, and thank you for joining Mental Health America on this webinar, Prioritizing Primary Prevention, Innovative Financing Mechanisms and Successful Community Partnerships. My name is Debbie Plotnick, and I'm the Senior Director of State Policy at Mental Health America. Today's webinar is being recorded, and it will be posted on the Mental Health America website. It will be available for download in approximately 2 weeks. I'd like to remind all the participants that your lines are muted. If you would like to ask a question during today's webinar, please type your question into the Q&A box located on the side of your screen. You can type your questions at any time throughout the presentations. We'll have several designated times during the webinar to address your questions. Community-based organizations and anti-drug coalitions promote the well-being of their local communities. Primary prevention activities are important components of an overall strategy for well-being. However, challenges to funding, implementation, and sustainability of primary prevention interventions can be barriers to successful prevention efforts. During today's webinar, you'll hear about some of these challenges and a number of solutions for funding primary prevention. And you'll also be introduced to several community organizations that have sustainable programs and partnerships. You will also learn about new opportunities under the Affordable Care Act and some innovative strategies for funding from private investors. We will begin with a welcome from Frances M. Harding, who serves as the Director of the Substance Abuse and Mental Health Services Administration Center for Substance Abuse Prevention, CSAP. Fran is recognized as one of the nation's leading experts in the field of alcohol and drug policy. CSAP provides national leadership in the federal effort to prevent alcohol, tobacco, and drug problems. As part of an executive leadership exchange at SAMHSA, Director Harding served as Director of SAMHSA's Center for Mental Health Services, CMHS, from July 2010 to January 2011. CMHS leads federal efforts to treat mental illnesses by promoting mental health and by preventing the development or worsening of mental illnesses when possible. Director Harding serves as the lead for SAMHSA's strategic initiative on prevention of substance abuse and mental illness, which creates communities where individuals, families, schools, faith-based organizations, and workplaces take action to promote emotional health and reduce the likelihood of mental illness, substance abuse, including tobacco, and suicide. Director Harding?
Thank you for that introduction. This webinar reflects another step in the evolution of prevention in behavioral health. This progress has come about through the use of data-driven systems and collaborative processes such as SAMHSA's Strategic Prevention Framework. The evolution has created new norms for the way the prevention field does business and has increased its credibility. Many of you represent programs and disciplines that have similar experiences across a range of prevention audiences. Growing recognition of the connections between substance abuse and mental illness and their role as determinants of wellness has been key to mental, emotional, and behavioral health, further known as MEB, prevention's growth and development. This public health perspective has driven the evolution of prevention as risk-focused, evidence-based, and responsive to population needs. Health reform aims to move to a payment system based on value. In doing so, it provides a climate that values prevention, addresses the whole person, and points to integration as the next frontier. The Affordable Care Act propels this movement through a number of behavioral health preventative benefits, as well as funding for community-based prevention and public health infrastructure. Many in public health, and more specifically in the behavioral health arena, have long sought to connect with health care's delivery systems. Currently, efforts by states and insurers to bend the cost curve by fostering wellness provides incentives for payers and providers to encourage communities rather than just treating patients. Today's focus on financing MEB prevention goes directly to the point of establishing new roles and relationships. Possibilities may include clinical prevention, connecting medical patients with behavioral health resources; population health, addressing the prevention needs of communities and at-risk populations as a basis for long-term improvements in health and costs. Increased emphasis on population health aligns with the strengths of coalitions. Knowledge of community strengths and deficits, visibility as advocates and agents of change, history of successes and prevention programming. The great capacity of coalition has been forged and steadily augmented through solid planning, evidence-based implementation, and demonstrated performance. We have well-developed systems, large and skilled prevention workforce. New financing approaches address perennial constraints. Cyclical, unstable, and fragmented funding occurs. Patient and illness-based insurance payments. To date, a number of experiments and innovations have emerged. Many of the initiatives taken thus far have involved state medical programs or specifically funded populations and health pools. Today you will hear about new approaches such as patient-centered medical homes, accountable care organizations, capitation payments, blending funding, or community wellness trusts. You will also learn about initiatives some coalitions have undertaken which enable them to participate in new financing opportunities. Whatever the financing mechanism, MEB prevention providers must be part of the change process. They must start setting goals for states, communities, or at-risk populations, assessing needs, prioritize the MED prevention, mapping your implementation, and estimating return on investment. These are familiar steps in the prevention community. As a field, prevention is highly skilled in well-structured planning and implementation. Issues affecting new financing for MEB prevention may include other health issues such as obesity and diabetes prevention may receive higher priority as payers. Providers and state leaders focus on specific needs, goals, or settings. Even when new payment models address a broad range of population health targets and determinants, questions remain as to what services will be paid for and who will be certified to provide them. The ability to show improvements in health, that's always a tough one for us. We have increasing body of evidence that MEB prevention works, but we must continue to develop metrics and build the case for returns on investment that may have a long-term horizon. Efforts to innovate MEB primary prevention financing are exciting and full of promise. As coordinating entities form and engage new partners, coalitions will be important voices for behavioral health audience and their prevention needs. Coalitions can help to shape changes in policy and practices. Key functions include assessing needs, reaching populations at risk, structuring services, or deploying community teams. Yet it is important to recognize that this is a work verily in progress. Research and demonstrations will be ongoing. Meanwhile, we must build on the great progress we have made in building capacity and effective service systems. New financing arrangements will call for new investments in planning, systems, and patterns of services. Be ready to test, explore, and adjust with us. Your participation will welcome contributions to emerging opportunities to advance MEB prevention. Thank you.
Thank you so much, Director Harding. That was Director Fran Harding from SAMHSA, and she is the Director of CSAP. Again, this is Debbie Plotnick from Mental Health America. Welcome if you've just joined us. Again, a reminder to participants that you are muted. Slides will begin momentarily with the next portion of our webinar, and all slides and a recording of this webinar will be available on the Mental Health America website in about 2 weeks. In this portion of the webinar, we will hear presentations that will provide background on prevention and which will present an overview on financing mechanisms and successful community partnerships. We'll hear from Sarah Steverman and David Shern. We'll also hear about social impact bonds and private financing from Max Crowley. Please let me tell you a little bit about our presenters that you'll hear from in this section. We'll begin with Sarah Steverman. Sarah Steverman, PhD, MSW, is an adjunct faculty member at University of Denver's Graduate School of Social Work. Sarah is an independent consultant. In her consulting work, she has provided expertise on HHS and DoD contracts related to mental health prevention and financing and implementation, sexual assault prevention and response, and behavioral health and sexual assault data analysis. From 2008 to January 2013, Sarah was the Director of State Policy here at Mental Health America. And at MHA, she was the lead staff person on state policy, health reform implementation, and prevention. She also closely monitored policy activity related to behavioral health services. Prior to joining MHA, Sarah conducted research and wrote reports on mental health issues and represented the state legislative positions on various coalitions as the mental health lead at the National Council on State Legislatures. She received her MSW and PhD from the Catholic University of America. David Shern, PhD, founded the National Center for the Study of Issues in Public Mental Health, which is a National Institute of Mental Health Funded Services research center. David recently stepped down from leading Mental Health America as President and CEO after serving since 2006. Dr. Shern serves on the boards of National Health Council, Campaign for Mental Health Reform, and on the National Advisory Committee for the Agency for Healthcare Research and Quality. And also in this section, we'll be hearing from Max Crowley, who is a prevention scientist and health policy researcher studying how to effectively and efficiently protect children and prevent risky health behaviors. Currently, Dr. Crowley is a National Institutes of Health Research Fellow at Duke University and a Research Fellow with the National Bureau of Economic Research. Dr. Crowley's work benefits from interdisciplinary experience in child development, family-based prevention, and public finance. He has received multiple national awards for his scholarship and currently co-chairs the Society for Prevention's Task Force on Economic Analysis and Prevention. We welcome them all, and I'm going to begin by turning things over to Sarah. Thank you so much.
Thanks everyone for joining us today. This is Sarah Steverman. We are going to get our overview of financing started, and I'm actually going to turn it over to David first, and then I will piggyback on his introduction and give a little bit more details about some of those financing mechanisms that I know you all are eager to hear about. So David?
on the line. David, are you with us?
Am I with you now?
Yep, David, there you go. Thank you so much.
Okay,
welcome.
Yeah. Boy, and you guys just missed this terrific introduction that I just provided to myself here and my cat. I guess the cat at least enjoyed it. What I was saying is, number one, thanks to Debbie and MHA for hosting this webinar, and thanks to Fran Harding for her great introduction. I think that Fran hit on several of the really important themes that are characterizing our field right now. I believe, and I think that we have increasing evidence that our entire healthcare system is starting to shift away from one that is almost solely focused on the treatment of illnesses to one that's really starting to look at issues in population health. And with the implementation of the Affordable Care Act, and we'll talk about that a little bit later today, there's clearly new recognition that we've got to move upstream ahead of the problems that we're currently confronting. And Fran hit many of those themes in her introduction. What I'd like to do too also is to thank SAMHSA for funding this work. We've been working with SAMHSA on a couple different projects that will result in 3 webinars. This is the first of 3. 2 of the webinars will focus on financing. The one today is intended principally for community-based organizations who are involved in trying to implement financing programs in their community. We have another one coming up Monday, which will also focus on financing, that has a broader perspective looking at the overall field in terms of the various partners who are involved in trying to develop sort of the public health infrastructure necessary for mental, emotional, and behavioral prevention. And so I encourage all of you to join us with that. That'll also be an MHA-sponsored one. And the third webinar is not the time for it is not completely finalized yet, but will be very, very soon. And that one really deals with what we're calling the next major era in public health. Our feeling, after having looked at the scientific literature, is that we're really at a tipping point here in terms of where the field is at. And we realize increasingly by our knowledge of the things, the developmental antecedents for first behavioral health problems and then later general health problems, that if we're going to deal effectively with issues of population health, we have to be addressing behavioral health. Our argument is that behavioral health is actually the linchpin for overall health. Behavioral health problems are the earliest problems to show up in development, and they signal and reliably predict later problems in general health. And Fran talked about that a little bit in her introduction as well. Problems with obesity, diabetes, cardiovascular disease, autoimmune diseases are importantly impacted by successful development. And so in that third webinar, we'll highlight the theory and the science and the empirical data that underlies what we think will be the next great era in public health. And as I said, we're going to probably be announcing within the next day the final time in which that webinar will be presented. And many of you who received notice of this webinar will also be notified with regard to that one. Now to today's matters. So what we want to do in terms of our presentation today is to present our sense of sort of the challenges and opportunities that we face as a society and as a field. Sarah will then talk about some of the challenges in terms of integration of services and some of the various funding mechanisms that are available from the federal government, from funding related to the Affordable Care Act, some really innovative insurance funding mechanisms that might be emerging. And again, Fran talked a little bit about that in her introduction in terms of some of the, as we shift to population health, our ability to use insurance mechanisms to underwrite primary prevention is increasing. There's some things that Max is going to talk about in terms of some very exciting new initiatives where private investors are investing in prevention, and owing to what we know about the return on investment from preventive interventions, they're being compensated for the risking their capital being paid interest on their investments from the funds that are saved by successfully intervening in terms of behavioral health and other kinds of problems. I'll then come back and talk a little bit about the issues in implementation. This really is a follow-along to some of the points that Max is going to make about how critical it is when we start looking at private financing, and I think we could argue even more broadly than that, how critical it is that we understand what we are in fact getting for our money. And that's the rationale that underlies these private financing mechanisms. And that really requires us to have good analytic systems, good public health infrastructure. Then finally, we'll end the presentation with two examples of successful community coalitions: the Five-Town Community That Care Coalition in Maine and Mental Health Association of Oklahoma's successful efforts, multiple efforts in blending financing and developing programs in Oklahoma. You know, we confront a lot of really important challenges as a society in the United States. We trail many other developed nations on many indicators of health and well-being, and there's increasing data that we're continuing to fall behind as other nations advance. I think that for this audience, likely people will understand the fact that the United States, according to the World Mental Health Survey, has the highest rates of mental illness in the world of the 17 nations that participated in that survey-based research project. The Institute of Medicine has recently completed a study comparing the functioning of the United States healthcare system relative to 16 comparable developed nations, and unfortunately, our healthcare system performs at or near the bottom on almost every indicator that the Institute of Medicine looked at. And this is in the context of the United States spending twice as much per person on medical care as any other developed nation, as any other nation. And we spend twice as much as all of our immediate competitors. So there's something clearly wrong here. We have the most expensive healthcare system in the world, and our performance in terms of our overall population health status, as is indicated by things like the prevalence of mental illness, as well as other performance indicators. Okay, we're not getting the value that we need for what is a considerable investment. You know, it's getting close to 18% of our gross domestic product. We have other social problems, I think, that we need to be quite concerned with as well. We have the highest rates of incarceration in the world. I think people are seeing in their local press almost daily continuing concerns with the rates at which we put people in prison. And although we won't talk about it today, with the treatment that people with mental illnesses and addictions receive, and by treatment I don't necessarily mean clinical treatment, but how they're treated in the United States penal system. And there's some, those are the contemporary institutions in which persons are abused. That being said, there's something wrong when we in fact lead the world in terms of the number of people per capita that we have in our prisons and jails. And then finally, for this little segment, there's increasing data that we're lagging the developed world in terms of academic achievement. So in terms of math and science and reading, we score near the bottom of developed nations in the Organization for Economic Cooperation and Development, or the OECD. We're scoring poorly on those dimensions, and unfortunately over the last 15 years, our performance has actually gotten worse. What we'll argue principally in that new public health webinar that I featured in my introduction is the fact that there's a theory that's clearly emerging that shows that early developmental challenges and adversities that are encountered by people have effects on their the development of their brain, with very specific effects on cognition, control of emotion, and executive control that subsequently lead to behavioral health problems and academic problems. Among the strongest predictors of academic failure are behavioral health problems. Kids who fail in school are on a trajectory to have lifelong problems in terms of occupational achievements, which leads to problems in their socioeconomic status, placing them at higher risk for adversities. And that's why we're arguing that the behavioral health problems are in fact a linchpin, and that it's critical for us to do what Fran was talking about in the introduction, move upstream, and these are very high leverage investments. The data that we presented here in terms of our challenges underscore the fact that these are matters of grave significance for us, and that this is an opportunity for us as a field to take the lead in terms of addressing what we argue are the public health crises of our time. We have a lot of opportunities, though, and again, I think as Fran mentioned in her introduction, we're coming to understand that behavioral health, which has been for many, many years considered and sort of as a segregated other specialty sector of care, is in fact absolutely essential to overall health. And as we just argued, behavioral health is a key factor in addressing these issues, particularly if you think about addressing the core root causes of many of our contemporary social problems. And we're lucky in that since an original 1994 report by the Institute of Medicine on the state of prevention science, we've invested probably not nearly as much as we should have, but we've invested in the development of some very solid science about what works in the field of prevention. And we have now a very strong literature that was summarized by the Institute of Medicine in 2009, which demonstrates that across youth and young adult development, we have multiple opportunities with science-based interventions that affect broad levels of human well-being. That's what makes these investments so appealing, is that although they're often targeted on a specific sort of problem behavior, in fact, when one has an organized and science-based approach to this, these interventions have broad scale effects. And as we've come to understand the importance of primary prevention and the antecedents for many of the problems that we have, what we've also come to appreciate is that given the broad-scale impact that prevention interventions have, the support for them, the financing for them, is also broadly distributed across a wide array of government levels. So there's funding that comes from local communities, states, and the federal government, across sectors of interest, juvenile justice, education, health, mental health, substance use, among others, are all interested and have programs that are directly relevant to primary prevention. And we also have funding, which spans the private sector, and I said Max will be talking a little bit about that. Public sector is the principal funder of many of these interventions, and of course philanthropy. Philanthropic sources are also important. And we'll be talking and providing examples from each of these sectors and from each of these funding sources and levels of government through the presentation. What we end up with is kind of a Rubik's Cube with regard to financing, and some challenges in terms of putting together a coherent strategy that we can use to understand our overall types and levels of investment. And I think you can see here what we've done is we've sort of demonstrated this the complexity by showing that there are national, state, and local levels of organization for preventive interventions. The blue field across the top shows the various sectors that are interested, and we talked about those as education, health, mental health, substance use, juvenile justice, child welfare, etc. And then there are several financing sources. So at each intersection of these three financing sources, there could be a particular program or intervention focused on a particular problem. And our challenge as a field, and the argument we're going to make today, is that community coalitions are particularly well positioned to address this challenge. Our challenge as a field is sort of putting Humpty Dumpty back together, or solving this Rubik's Cube, so that we can understand the scope of our investments, understand and identify areas in which we currently don't have adequate coverage, and somehow better coordinate and lead our nation in terms of maximizing the investments that we have already made, identifying areas where we need to make additional investments, and being sure that we have a rationale, understanding, and strategic leadership for this very broad level of concern. So the good news is primary prevention interventions have broad beneficial impacts across these various dimensions of human health and well-being. The challenge is that because of those broad-scale effects, our investments are broadly spread. Our argument today is that community coalitions are in a very strong position to help integrate those funding mechanisms to rationalize the programs because they're so close to the ground and are so close to the challenges and opportunities confronted by their community. So at this point, I'm going to hand it back to Sarah, who will talk a little bit more about these challenges and then start to feature some of the funding mechanisms that are available for this broad panoply of prevention intervention. Sarah?
Thanks, David. Thanks to MHA and SAMHSA for having us all together today. I'm going to go relatively quickly through some of the challenges. I think David really framed it pretty well. But I do want to introduce a phrase that Max presented to us, and that's the wrong pocket problem. And David alluded to this and began to speak about it. But that's the idea that we have many diverse sources and diverse human service sectors that are all working on the same problem. We're all concerned with promoting individual, family, school, community well-being, population-level well-being, and we invest in different ways and different interventions, and we're not necessarily aware of the investments that are coming out in different outcomes. So, as an example, in education, there may be an investment in promoting pro-social behaviors and classroom management using the good behavior game. And we're going to see it. And so those investments are made by the education department in a state or in a community. And then down the line, we see reductions in smoking, and we see an increase in educational attainment, which is, of course, the goal of the educational system, investing in that. But we also have those savings ending up in other people's pockets. So in behavioral health and healthcare, and reduction in smoking, and reduction in juvenile justice and criminal justice, potentially reduction in child welfare. And we'll get into a little bit more about how we know about those indicators. But I just wanted you to think about that there are many people working, many different stakeholders working on these issues across various sectors, and we need to be able to understand what's being invested, and then what are the outcomes of those investments. And of course, one of the main challenges is identifying sustainability. We have some demonstrations that we know about, and we have some research that has demonstrated effects, and we need to know how to bring those to scale and keep that funding coming. And of course, as David said, community-based organizations and coalitions and those on the ground can really be drivers of these activities and really understand what those investments are at the community level and what those outcomes are as well. So David really covered this, I think, and I do want to get to the financing mechanism. But there is a lot. I think just the number of people who are interested in this webinar alone is an indication that we are moving towards an understanding that we can promote health and we can prevent health and social problems, that there are a lot of people in this, that we just need to kind of identify who they are, what they're doing, and work together and get those systems working together. And again, here are some of the outcomes that prevention interventions, whether we're talking about individual programmatic interventions, clinical encounters, or we're talking about environmental and community-based population-level interventions. They are aimed at promoting pro-social behaviors and reducing risk factors So we're talking about not only getting the good behavior game into schools, but we're also talking about reducing poverty and reducing violence and reducing family dysfunction, all of those risk factors that we know impact behavioral health over the lifespan, as well as impact various sectors in the child welfare system, the criminal justice system, the healthcare system, et cetera, et cetera. Occupational achievement, David mentioned that, promoting psychosocial and interpersonal functioning. And then, of course, what has been the focus of much of our work in the behavioral health community is the prevention of mental health and substance abuse conditions. And we often think about the science base as demonstrating these reductions in kids, but we're really talking about the entire lifespan. We have seen a large focus in the military on resilience, workplace wellness initiatives to improve the workforce, improve employee and their families' health, and substance abuse prevention and mental health promotion in older adults as well. So this is really a lifespan issue that we're talking about. So here are some of the human service sectors that are interested in this issue, and that we should all be working together with to improve human capital. We really, David touched on this. We really have a depleting workforce, and which is a product of our poor health and behavioral health and educational attainment. And large numbers of people in the criminal justice system, and so we need to be understanding of these various sectors that are working together, and how they impact various social goods, societal goods, and it's not just the government that benefits. There are benefits to the business community, the community and civic engagement, people being involved in their communities and their neighborhoods, and then of course individual and family well-being that is impacted. This is from the Washington State Institute for Public Policy. This is just a few of the interventions that they have studied. They have done cost-benefit analyses on to demonstrate that we really do have interventions that have an impact across the board. So you look at the Seattle Social Development, which targets youth in grades 1 through 6 to increase bonding in school and family, and it protects against school failure, delinquency, drug abuse, teen pregnancy, and violence. So it has a broad range of outcomes that has been demonstrated, and the total benefit per person is $15,238, and then you'll see that they have calculated what the benefit is to the taxpayer, so what the government saves by investing, and then the cost of it. So you can see here for all of these interventions that investing in what we know works and implementing with fidelity and ensuring sustainability, that is going to bring a benefit to both the taxpayers, to the government, as well as to the community as a whole. So I commend you to the Washington State Institute on Public Policy. They have some really good data on lots of different interventions. There's just a few that I picked out from their prevention literature, but I commend them to you, and I think that David might mention them again in implementation when we talk about that. So here are just some overarching goals. What we're really talking about here is both environmental strategies, creating nurturing and caring environments that promote health, and then also programmatic or individual primary prevention strategies and programs that are available to everyone, and that we really consider them, just like we consider vaccines to prevent general health conditions, that these are evidence-based programs that can be available to everyone to promote health and inoculate our kids and our families, especially at this stage, from mental health and substance abuse problems and other social problems. So I'm going to get into some of the mechanisms here that we can use for prevention that maybe you haven't thought about or weren't aware of. And we're going to have a little bit of time for questions. But as we're moving towards prevention, there's an increasing recognition that this is an issue, that there's an interconnectedness between health and social problems. So addressing health is going to have those ancillary effects. And as Max is going to talk about, that there also is an interest by businesses. They understand that it's in the best interest of themselves and best interest of the business, the community, and society as a whole. And then here's just another couple of constraints of prevention financing. Only about 3% of federal funding goes to healthcare expenditures in this country, compared with 97% that goes to treatment. So there's a significant imbalance there. And then we really have set up our healthcare system to be a medical care system, focusing on treatment, and we have medical necessity criteria that generally needs to be met before a service can be provided. So if you if you haven't presented a problem, then you probably aren't going to get the service, rather than getting ahead and getting upstream and preventing those issues with some sort of preventative vaccine, for instance. Fee-for-service incentivizes treatment, so the more you do to a person, rather than preventing the need for all of these treatments, the more you the more you need, the more you're going to get paid by insurance companies. So that has been a disincentive for prevention. And then historically, beneficiaries have been able to be booted off of insurance. There's been mobility between insurance carriers. Of course, that ended with the ACA's guarantee issue, January 1st, 2014. So you can no longer lose your health insurance due to a condition. But that mobility of beneficiaries meant that there wasn't an incentive to keep people healthy because you could just drop them from your insurance plan. So that is shifting, and that's really an exciting shift that we'll talk about a little bit. And then another issue has been the individual beneficiary versus the family or the population. So a lot of the interventions that have demonstrated effectiveness are aimed at parents to help them to raise healthy kids, and it can be difficult to administer an intervention to a parent when the beneficiary is actually the child, when they don't have the same insurance, and there isn't the incentive there to do that. So that has been one of the issues with our insurance-based system of medical care. So here's just a list of federal financing, and I'm not sure if David mentioned it. I don't think he did. We did write a paper that has a lot more information that we'll commend you to, that will be up on MHA's website, that has a lot more details for you on all of these issues, and it will direct you to that. And we're not going to have time to cover it all today. But of course, the Substance Abuse Prevention Treatment Block Grant, 20% of the block grant is required to go to prevention. So that's a major source of prevention financing for the states. And then SAMHSA has several discretionary programs, some of which Fran mentioned in her introduction, that have demonstrated effects in the community. Project Launch, Safe Schools, Healthy Students, Strategic Prevention Framework, several programs, and technical assistance that SAMHSA has provided to organizations and communities and states to try to consider what they can do to promote prevention. And then across various agencies, HRSA, CDC, the Department of Education, Housing and Urban Development, a lot of community development grants that HUD provides, child welfare, Administration on Aging, and then, of course, the drug-free communities that the Office of Juvenile Justice and Delinquency Prevention and SAMHSA together administer. they're all doing their part to provide funding to states for prevention. And then I'm going to talk a little bit more in detail about some of the ACA and Center for Medicare and Medicaid Services programs or interventions or strategies for trying to move us upstream into a prevention-focused healthcare system. So in the ACA, passed in 2009, 5 years ago now, there is explicit recognition of the critical nature of prevention. It was a big focus. Many people often think of the Prevention and Public Health Fund, which is many billions of dollars over the next several years. In 2021, we'll be at $2 billion a year that's going specifically to prevention. And there are lots of different, it's being used for several different grant programs and initiatives. The Community Transformation Grants are providing states, tribes, and communities with funds for population-level health. SAMHSA administers some of the funds for the National Suicide Prevention Strategy, and also to improve some surveillance that the CDC's BRFIS, the Behavioral Risk Factors Surveillance System, does to try to develop the public health infrastructure and monitoring, and some prescription drug monitoring systems. So SAMHSA as well as HRSA and CDC have control or are involved in the allocation of the Prevention and Public Health Fund, which is a major driver of grant funds for prevention fund financing. And then the U.S. Preventive Services Task Force, those requirements, they have reviewed the USPSTF, which is kind of fun to say. They review clinical preventive services, and those that have received an A or a B rating by the USPSTF are required to be covered at no cost to the beneficiary. So for mental health and substance abuse, that's alcohol, tobacco, and depression, some violence screening, interpersonal violence screening. And so those are already part of the essential benefits package, and they're already part of what is required to be included in everyone's insurance at this point. Universal coverage is the broad goal of the ACA, that everyone have insurance. And we focus on this here because it really is going to be the driver of change. It's going to be what gets insurers, employers, public and private payers of medical care to really move toward upstream preventive population-level health. We, as states implement Medicaid expansion, for those that are implementing the Medicaid expansion, and as the insurance marketplaces are up and running and people are able to get insurance who were not able to get them and can't be denied insurance based on any pre-existing conditions, we have more of the population covered, and therefore more of an incentive by those who are paying for insurance to move towards preventive services to drive down the costs and drive down those deep-end costs of hospitalizations and chronic disease management. And then risk-based financing is another form of universal coverage, kind of. In Oregon, coordinated care organizations are geographically based insurers that cover all of the Medicaid population in a given area. And in Oregon, in Lane County, Oregon, Trillium Healthcare, the provider there, the insurer there, has decided that they want to implement the good behavior game in classrooms that have a large percentage of Medicaid beneficiaries, with the idea that in 15 or 20 years they're going to see effects of reduced smoking, reduced behavioral health problems, reduced health problems, reduced criminal justice problems, all of these effects that the good behavior game has. Not to mention educational attainment, but they have really decided that utilizing preventive interventions is the way to go, and they're moving into the schools, which is unusual and kind of novel for insurers. And then community benefits requirements for nonprofit hospitals. There are, as many of you know, in your community, your nonprofit hospitals are required to provide a certain amount of charity care. And as we're moving towards universal coverage, again, we're getting back to this this issue where fewer people are going to be lacking coverage, so fewer people are going to need charity care. Those benefits that the amount of money that they are required to provide for the community's health can go to population-level interventions. And there are new requirements by the ACA to require needs assessments and integration with community stakeholders. So be on the lookout for what your nonprofit hospital is doing, especially if you're in a state that's expanded Medicaid and you're really reducing the number of uninsured who are showing up at the hospital. They're going to have resources that will need to go to charity, and the way that will manifest itself will likely be in population level interventions, surveillance, and working with stakeholders to solve some of those issues. Another way that we're seeing prevention become more prevalent and a bigger priority is with a few Medicaid waivers. In Washington, the state has developed a new CPT code for Medicaid to bill for triple P in clinical settings. So these are triple P levels 2 and 3, which are brief interventions when a parent comes in and is seeing an issue or having some behavior problems that they would like to some help with, some assistance with. The clinicians can actually bill a certain code for triple P. And then in New York, there's an 1115 waiver amendment that is just getting rolling. So we are still determining how it's going to roll out. But the Delivery System Reform Incentive Payment has a focus on population level health, and there's a goal of reducing avoidable hospital admissions by 25% in the next 5 years. And they are looking at, in addition to service delivery reforms, they're also explicitly looking at population-based strategies. And they've actually named promoting mental health and preventing substance abuse and promoting the health of women, infants, and children as some of those sub-areas that are going to be part of that Delivery System Reform Incentive Payment Program. So we will be watching that. And then lastly, some other sources that you can be considering in your community. I know many of you know about special taxes or levies, excise taxes that are on tobacco or alcohol, which often drive down the rates of drinking and tobacco use, are one source of prevention funding if they're designated as such. Or a percentage levies that are a percentage of the property or income taxes. Seattle keeps renewing a levy that goes towards education and primary prevention. They keep renewing it every 3 years because they really see the benefit of those dollars. So they keep taxing themselves through referendum because they do see how that impacts the community. And some foundations, of course, health conversion foundations, also called New Health Foundations, are in your communities and states. These are forms when nonprofit hospitals or health systems are converted to for-profit entities. And at last count, there was 200. I think that there probably are more now. But many of them have quite a bit of resources and are really, really focused on population-level health. Wellness Trust was an idea that was introduced by the Brookings Institution in the mid-2000s prior to the ACA, but really was trying to identify a way to take prevention out of the health and medical system, to provide a public health infrastructure that's available to everyone based on funding from private and public insurance as well as the current public health funds. And this hasn't taken off, although in Massachusetts, where many ideas are started and grow. They do have a wellness trust that they have just started, and they are pooling funds from the state to fund population-level prevention. And then lastly, reinvestment compacts. This is something that at the community level should really be on your radar. As these investments in prevention funding are made, and with good data, we'll talk about this a little bit later, but with good evaluation, we can understand what those impacts are, and then that funding that is saved or the expenses that are saved should be reinvested back into the community, either into the same program or into another prevention program. So I ran through this quickly, but we're behind schedule, so I apologize. We're going to turn it over to Max, and he's going to get into some of the private insurance, or no, not insurance, sorry, private investment from the business community that we're seeing bubbling up across the country. Max?
Thank you, Sarah. So I'm going to provide a brief introduction on a relatively new funding area known as Pay for Success, or PFS. And PFS is an outgrowth specifically of performance-based contracting that has become particularly valuable for tying contract payments to actual receipt of products or services. So Pay for Success financing applies this approach to the delivery of health and social services, tying public payments to actual verifiable outcomes. And specifically, a PFS contract leverages private investment in interventions to prevent downstream public costs, as we've been talking about here today so far. If this public cost aversion then is actually achieved, then government shares the savings with private investors through the repayment of the initial outlay that the investors make, as well as a small return on their investment. So one of the common structures of such a contract are known as social impact bonds, which I think some of the group may have heard about before. So these social impact bonds rely on an independent evaluator to determine if that cost aversion has actually occurred to trigger these so-called performance payments. So if the program fails to achieve the previously agreed upon level of cost aversion, the level of savings, then the performance payment is not triggered. And the private investor has already spent their resources, their investment, and they lose that investment. But public resources, public dollars, are protected. So Sarah, thanks for switching the slide. Sorry, you can back it up. So PFS contracts allows public entities to engage new financing sources to meet pressing social needs. Specifically in the context of diminished public budgets, governments can turn to the private sector for investment in mental health and welfare. And when a program has strong evidence that it can achieve significant cost aversion, cost savings, but spending concerns that we've been talking about today block its support, then government can incentivize private investment in the program by offering to share in eventual downstream savings. And this has real implications for community-based nonprofits on the ground who are actually delivering services. So we're finding that there is substantial demand among a broad class of private investors to support such programs. For instance, it took Merrill Lynch only 60 days to raise the $13.5 million it needed to support last year's New York State Pay for Success contract that delivered cognitive behavioral therapy to juvenile offenders. And its investors in this bond, in the social impact bond, included former U.S. Treasury Secretary Lawrence Summers, Utah philanthropist James Sorensen, and the Laura and John Arnold Foundation, as well as a broad group of other individuals. So while the cause of reducing juvenile offending may be in the public interest, and in particular preventing violent activity and violent delinquent behavior among juveniles, these investors also stand to realize annual returns of up to 12.5% over a 5-year period by helping the state and helping the state in this context prevent the costs from having to incarcerate juvenile offenders. So such investments illustrate that funding for social programs may in fact be available when thoughtfully framed within a PFS or pay for success structure, whereas it might not be available if we look for public funds. So in 2010, the first PFS contract was signed in Peterborough, UK, the United Kingdom, to prevent recidivism among juvenile offenders. And in this agreement, investors funded a program to reduce reoffending among prisoners leaving the Peterborough jail. If the reoffending rate is lowered by 7.5% within 6 years, then the UK government will pay the investors back their initial investment and a share of the savings from having to incarcerate fewer youth. Interim findings so far from the Peterborough trial are highly promising, with a 12% decrease in reoffending compared to the national average. Now, in the United States, the past 2 years has seen an exponential increase in pay-for-success interest in implementation. The first was through a contract between Goldman Sachs and the City of New York to prevent recidivism of juvenile offenders on Rikers Island, as I was previously talking about. And then another pay-for-success contract in Salt Lake City is currently seeking to reduce special education costs with a high-quality preschool intervention. A pay-for-success contract now in Fresno, California supports a behavioral management program for children with asthma in an effort to reduce emergency care costs to the state Medicaid system. There's numerous other efforts out there that are driven both by policymakers as well as private investors, which are currently being explored. So now I'd like to step back and consider what the structure of a pay-for-success contract can look like and who the key stakeholders are, more importantly. So while many of these efforts have initially focused on prevention efforts that target specific at-risk populations, this financing strategy can be applied to primary prevention when savings are known to exist. So as was mentioned earlier, it's very important that we have good evidence, strong evidence of the effectiveness and also the impact, the fiscal impact of the programs that we seek to implement. So some of these programs already have been discussed, are excellent candidates, CTC for one, for this financing strategy, and I think that there's a broad array out there, and we have to develop the evidence to support them. So pay-for-success financing centers around contract development between multiple groups in an effort to align stakeholder incentives and for supporting these mental health services. In this manner, they are a new asset class that can funnel private sector capital towards services generally supported by public entities. While implementation and metrics of these pay-for-success contracts can vary, they share a series of common structural elements, and this includes a government agency partner, a private investor, and an intermediary organization. The government agency partner and investor develop and agree upon a contract with the intermediary organization. And so in the case of the first U.S. bond on Rikers Island, the City of New York partnered with Goldman Sachs through MDRC, the Social Policy Research Group. And the investors then provide the initial capital while the intermediary oversees the actual programming, actual delivery of programming. And so in New York, the Osborne Association and Friends of Island Academy, those community-based organizations deliver cognitive behavioral therapy to juvenile offenders before they're released from detention, and then other supportive behavioral services post-release. So now these juvenile offenders are being tracked to follow who is recidivating and who is not. And this is done through administrative data systems leveraging electronic juvenile justice data. So it's very important, that access to administrative data. And the Vera Institute of Justice will then conduct an independent evaluation of the impact of these services on both the juvenile offenders as well as the public costs for recidivism. So if recidivism is reduced by 10%, then Goldman Sachs will receive their initial investment back. And if recidivism is reduced more than 10%, then the city will pay an additional return on that investment. But even with these additional payments, the city will still see an overall net reduction in criminal justice costs. So while pay-for-success is a rapidly expanding area that offers interesting opportunities for financing some mental health services, this approach is not without inherent risks and pitfalls. So in particular, there are concerns that the financial motivation, and I'm sure some of the people on the phone may share this, that the financial motivation within pay-for-success financing may bias efforts to evaluate the success of different programs. And what is being emphasized in the field, both in social finance as well as the other groups and researchers that are working with this, is the importance of high-quality, independent evaluations, so evaluations that can't be impacted by any of the stakeholders involved. Further, that's particularly important because of the tremendous appetite among private investors. But it is important to recognize that already this financing structure is bringing substantial amounts of money to mental health services, millions of dollars already, with groups like Bank of America and Goldman Sachs viewing this as potentially a multi-billion-dollar market for their private investors to actually put their resources. Further, as Sarah mentioned earlier, we have to recognize that savings often comes outside of mental health care as we see it, and we have to move past the traditional silos that we're often forced to work within and focus on that we may be intervening in mental health here, but the savings are to juvenile justice or education or the education system or to physical health care, and that's very, very important that we understand that we're making these upstream investments strategically. And lastly, it's important that we need to ensure that programs have high-quality evidence of public savings, and I can't emphasize that enough, that high-quality trials are very important to understanding what programs we should invest in and can invest in and what programs may not be quite ready. So thank you.
Thank you, Max, and thank you, Sarah and David. Again, this is Debbie Plotnick at Mental Health America, and we had planned to put a question and answer portion at this point in our program. We're running a little behind schedule, so we're going to save our questions to the end. If you have a question, please do put it in the chat box, and we will get to it. I'll remind everyone that their phones are muted. Questions by chat only. Again, the webinar is being recorded. It will be uploaded to the Mental Health America website within 2 weeks, and the slides will be available for download at that time. I'm going to move ahead here and introduce our next set of presenters. Dr. Sherman will return for a very brief overview of implementation, and then we're going to hear about two outstanding community organizations, the Five-Town Communities That Care, which is a community prevention agency in Rockport, Maine, and the Mental Health Association of Oklahoma, part of the MHA family. I'm going to very quickly introduce our next speakers. Daylene Dutton is the Executive Director of Five-Town Communities That Care, and in addition to providing oversight for this agency's local operations, she also provides consulting and training in the Communities That Care system all across North America. She's presented at many national conferences, and she is an appointed member of Maine's Juvenile Justice Advisory Group, where she co-chairs its Youth Engagement Committee. She has an undergraduate degree from the University of Maine, Orano, and a graduate degree from Lesley University. She is the recipient of many awards and has been recognized by the Maine Commissioner of Education and the Maine Alliance for the Prevention of Substance Use. She is a native of Maine, and Ms. Dutton and her husband raised their 3 children on the family farm in the small town of Morrell, and they still reside there. We're also going to hear from Michael Brose. Michael W. Brose, MSW, has dedicated his life to the eradication of stigma and discrimination aimed at people affected by mental illness. He's the Executive Director of the Mental Health Association of Oklahoma. MHA of Oklahoma was, when Mike assumed leadership, an agency that could only house 12 people. And Mike could count the staff members on one hand. But today, MHA of Oklahoma owns and manages nearly 900 units of housing dedicated to serving homeless, mentally ill individuals and people who are also at risk of becoming homeless. Now, Mike supervises a staff of more than 150 employees. And under Mike's leadership, MHA of Oklahoma has grown dramatically in the areas of advocacy, education, prevention, and housing of people who have been homeless and mentally ill. In 2010, MHA of Oklahoma won the Oklahoma Center for Nonprofits Award, top nonprofit award for the entire state of Oklahoma. David, would you give us that very brief overview, and then we'll hear from Daylene and Mike.
Yeah, Debbie, I'd be delighted to do that. Basically what we were going to talk about were some key aspects of implementation. And as Debbie said, the slides will be available for everyone on the website. And Sarah mentioned the paper, which goes into great detail really the moral of the story is, just like we know a lot about the issues involved in successful prevention, we're learning more and more about successful implementation. And Mac's presentation really underscored the fact that if we're going to move into this private financing area, and I think we could argue increasingly in the public financing area, it's critical that we be able to document what we're doing and document the broad-scale social benefits for it. So I recommend our paper to you that goes into greater detail. But without further ado, I'd like to turn it over to Daylene to give us some concrete examples about the work that they've done in developing sustainable long-term programs in Maine. Daylene?
Thank you, David. First of all, I just wanted to give everybody a really brief overview of our community. We are a very small community in Mid-Coast Maine, only about 13,000 people. And in 2003, we were really struggling as a community with how to get organized, how to fund, how to implement mental, emotional, and behavioral supports in our community. We had lost, in our small high school of 600 kids, we lost 5 to suicide in 1 year. We had 2 young ladies killed by a drunk driver, and we had a young man who drowned while hunting, duck hunting in a canoe, and they were intoxicated and overturned and drowned. So you add this, all of these things together, really our community was in a place where we needed some assistance with how to get mobilized, how to get organized. And fortunately for us, the Social Development Research Group at the University of Washington was just getting ready to undertake an efficacy trial of the Communities That Care system. And so we were able to take part in that trial. And being involved in that trial gave us some funding to get started. But just as importantly, it provided us with extensive training in Communities That Care, and the components of Communities That Care, which includes coalition development, prevention science, data analysis, and data utilization, and program evaluation. So we had a good, solid education. And when I say that the training, we were provided with training, very often when training happens in the community, it's for a few individuals in an organization. What happens through the CTC system is that the training is delivered to a large number of people in the coalition. So, 45 to 50 people in our community all had access to training in prevention science and data analysis and evaluation, all of these things. I just wanted to put some kudos out to CSAP again. The initial funding for this research trial, the Community Youth Development Study, was funded in part by CSAP, as well as many other organizations, federal organizations. So once we had 5 years of funding through this research study, and while we were still under that funding umbrella, we were able to attract some additional funding as we were getting our feet underneath us and learning a little bit more. So we first started looking for funding from corporations. We were successful in attracting some funding from the Verizon Foundation. We had some local foundations, and we actually were able to attract some pretty significant donations from some local donors. But I can't emphasize enough that having good local data that we could clearly tie to desired outcomes, and having established partnerships and a desire to form true coalitions. I'm going to talk about what I mean by true collaborations, in just a moment. But this really positioned us much more favorably in funders' eyes. And as we were under this initial funding umbrella, we really were learning much more about how to make our case using data when we were addressing funders. So this is a little bit confusing, but I just wanted to point out that one of the advantages that we had is that we could demonstrate how different interventions can contribute to a particular problem behavior. So we could talk about the fact that we were addressing, as a coalition, a broad-based community coalition, adolescent alcohol use, and that we were doing so through a variety of different interventions which were being implemented by many different coalition partners. And we were able to tell the story of how each of these interventions were affecting the different mediators and then show how they were all together contributing to the decrease in adolescent alcohol use. So we got to be very good at tracking these program level outcomes, intermediate outcomes, and long-term outcomes, and not only tracking them but communicating them. The other kind of twist on this is that we found that because the CTC system helps us to really focus upstream, as David mentioned in his comments, if you focus on a risk factor or a protective factor, something that predicts problem behaviors, very often one particular risk factor can predict a variety of outcomes. So for example, in my community, we implement Guiding Good Choices. We can show that Guiding Good Choices can influence family conflict in a positive way. We can then demonstrate that family conflict, reduction of family conflict, can have effects on substance abuse, depression and anxiety, violence, delinquency, school dropout, or teen pregnancy. Because we can show these broad effects, we can approach a variety of different funders to look for support for these programs so that we can blend. Using the data, we're better able to make a case for blended funding. One of the other things that I think is really important to point out is that we have frank, regular discussions amongst all the coalition partners and organizations in our community that really allow us to be able to minimize duplication of efforts. And it forces us, I think, because we do have these conversations, to really consider new partnerships. The partnerships might be anything from collaborating to deliver a program, to endorse one another's programs across different agencies, to make sure that we're being really thoughtful about how we share information. We have begun loaning one another specialized staff. So for example, if one organization has a statistician, they might loan that person to another agency in the community. We do joint fundraising events as well. So as part of the CTC process, we engage in a data gathering about who's doing what goals individual organizations have, and we really sit down and make sure that we all together have a good understanding of what one another are trying to accomplish, and look for ways that we can avoid duplication and leverage one another's talents in ways that help us all achieve our goals. This is, I know, a little grainy image, and it also has a lot of things going on, but the reason that I really wanted to put this in front of you is to show that we take, for any particular program that we're attempting to implement, we have a variety of ways to support it. So if you look kind of in the center of this diagram, there's something that says STAR. That stands for a program called Skills Training and Recognition. And this program provides promotion of positive youth behaviors. And so we have funding through the Office of Juvenile Justice and Delinquency Funding, which is passed through Maine's Juvenile Justice Advisory Group. But that funding is accessed through a joint application with another agency that's also providing services in the community. So we get support from federal funding passed through the state. Local businesses are donating materials, donating space, helping us to promote the program, in some cases helping us to transport youth in the program. And then we have in-kind donations from over 20 businesses and agencies in the community that also provide space for these programs, for the sessions that are part of STAR to happen. If you look at Guiding Good Choices, we've got community agencies that are providing space for the Guiding Good Choices sessions, and local churches in my community actually have come together and provide funding to pay the facilitators and to provide incentives for participation, such as providing child care and meals for the families that are taking advantage of this program. So current funding, as far as my coalition goes now, we are able to attract significant support from local donors and from local fundraising events that are undertaken as collaborative efforts from, with not just our agency, but a lot of the coalition's partner agencies. I can't say enough about the impact that in-kind donations have made and what we're able to do, especially in terms of direct service for youth programming. We've been very successful in bids for state funding, especially through delinquency prevention. We have now local municipalities that are routinely including us in their budgets. And then the last part is that we've been able to leverage our expertise as a coalition to generate a modest income stream from consulting. So we know that we've learned a lot, and we found that by sharing what we've learned, we can not only help other agencies, but if they can provide a modest fee for us helping them, then we can also benefit because we can apply that funding to our local prevention efforts. So points to note, and I'm trying to be quick here so that we can get to the other presenters, but use of data is critically important. You need to have good data. You need to understand what the data does and doesn't tell you, and you need to become pretty accomplished in communicating the data. For example, you can't just put a bunch of statistics in front of the town managers and those that manage the town's business. You need to be able to clearly tie the data on program outcomes and intermediate outcomes to long-term behavioral change. True collaborations are extremely important. Very often I think when you have agencies that are doing social services apply for grant funding or work together, it can tend to be on paper collaborations. You know, we do a letter of support or we agree to provide this piece of service. True collaborations are much deeper in the way I'm referring to them, in that we learn a lot more about one another's organizations. We include one another in the individual organization's strategic plans. We routinely look at one another's annual plans so that we better understand what we're doing and we recognize where we have overlap in our goals and where we don't. The third thing is by really looking upstream, focusing on predictors, risk and protective factors, we can affect those multiple problem behaviors. Having a clear understanding of which problem behaviors that the evidence says that our interventions can affect allows you to make a good case towards different funders. Fourth, develop your capacity as, if you're working especially in a coalition, really think about the capacity that you have within the coalition, how to develop it, and then consider how you can use it to perhaps leverage a modest funding stream. The last point I think is an important one, putting community needs first. That was a big learning curve for us, is that we needed to go into our planning sessions, that we needed to make sure that we had a good data set about what the community needs were and that we were looking at those rather than what the agency needs were, and always starting from those. So I think that pretty much is the end of my presentation.
Thank you, Gayle.
Okay,
Thank you so much. Mike, you're on.
So Health Association Oklahoma. So again, kind of just to put you a little bit in context of what it's like here. Again, we are a downstream state, meaning that we address things in a non-preventative way. We tend to do it in a more expensive way. We've rejected Medicaid expansion politically. But at the same time, you can see from our perspective here in Oklahoma that prevention is bleeding through our red borders, so to speak, and that everyone, that this is a moment in time that we have to grasp at the local and state levels and take advantage of it, because this is a very key moment in time where everyone in all kinds of ways are talking more and more about prevention. You can see by one of our ways, again, developing partners and finding champions, not only in our community where I live in Tulsa, but now we're developing champions in other parts of the state and developing public partners. And I just want to note that our 20th annual Zero Symposium, which some of you may have even attended, is next week or 2 weeks from now, and it's all things prevention. So it kind of shows you the level of how everyone is talking about prevention, even in a red state that's rejected Medicaid expansion, and that we're still now beginning to start to think and move upstream. Again, 2 areas I'll talk about very briefly. I know we're running short on time. I'll try to be very concise here. So in terms of getting into and building partnerships with schools, if you've worked with schools very long, you know that when they see you coming, they view you as an add-on, and it takes a while. And so what we've had to do is basically when they've got themselves in a crisis, sadly, it's been death by suicide, it's been accidental death, a number of things. We've always responded to those crises, and so that's allowed us to build credibility in the school systems. And so we actually, all the way back to year 2000, we brought, through TeenScreen, we brought primary screening and a program that we developed, and SAMHSA originally helped us fund to get started, and we've been able to sustain, called Safe Team, and we've been able to bring those into school settings, and that was, again, that was a very novel idea at the time, but now it's accepted, and it's we were able to actually seed it over in the Oklahoma City, Central Oklahoma area, and it's very active over here also. So again, we provide whatever, we were highly flexible, trying to work with those schools, and Daylene talked about building those other partnerships. We also developed it's called the Community Systems of Care Community Team, where we bring all the different providers, advocacy groups around the table, trying to work together, minimize duplication, again, in follow-up to what she talked about. And again, we also then raised private money and went into primary care settings to help them set up and do paper and pencil screenings, behavioral health care screenings in those settings, targeting pediatricians, primary care aimed at adolescents, and got some success there. We're actually, I think it was, in hindsight, we were probably a little bit ahead of our time. So again, trying to locate funding through private foundations and corporations. Again, a lot of people and a lot of organizations look always to the public sector because we have such limited public sector access through our state systems here in Oklahoma. We've reached out to the private foundations, but then again later tapping in, that allowed us to build a foundation to tap into Garrett Lee Smith funding. Okay, next slide. So our other areas, was other than schools and youth reaching out and developing those coalitions, it's been housing first and developing housing. And as it was mentioned, Debbie mentioned, it's actually about 850 units, 20 different apartment buildings in 16 different neighborhoods, debt-free owned. How did we do that? Well, we actually, again, we reached out to the private sector, and we raised in total over the last 20 years, we've raised that about $50 million from primarily the private sector, although we have used that to leverage a lot of public funding. And again, a side effect of that is preservation of affordable housing. Again, in many areas of the country, you see gentrification destroying affordable housing in a lot of communities and making that go away. By owning our properties and debt-free and controlling them, we've been able to slow gentrification, and that's becoming an increasingly a bigger issue in more parts of the state and the country. So again, we built partnerships through that with housing authorities and also now private developers. So again, funding streams with our housing, how have we done that? Well, again, the funded capital campaigns, funding both bricks and mortar and services I mentioned. We have had many areas of the country using housing tax credits. We have done that on a limited basis, and we are continuing to be open to that, but we've been able to fund our housing debt-free, and it's allowed us not to have to rely too heavily on housing tax credits. HUD Continuum of Care, HUD Home Funds, ESG, now rapid rehousing through HUD, again applying to SAMHSA grants. We just recently were notified that SAMHSA has funded a collaboration agreement to fund to benefit homeless individuals, the CABI grants. We were notified here in Oklahoma that it's been funded by SAMHSA. We're very excited about that. State contracts, VA contracts, and now we're in the process of applying for funding to federal home loan banks. The one we're targeting right now is the one in Topeka. So blending a lot of different funding streams, having private money leverage public money. So that concludes mine. Thank you.
Thank you, Mike. Thank you, Daylene. Again, this is Debbie Plotnick with Mental Health America. We're going to take a couple of questions. We're running a little over time, but we did want to give our presenters a chance to speak to some of the questions. I think one of the things that's on people's minds is how can we measure the impact of these prevention efforts, and how can we make them understood by policymakers? How do we get these alliances that will help us bring in municipalities as well as private funding? Would one of our presenters like to address that?
Yeah, this is Mike Brose. I'd be happy. We developed and worked in the leadership role under our advocacy work to, it's called A Way Home for Tulsa, which is now 24 different organizations. And we went to, again, started through private funding, but built into that evaluation, and now we're getting tremendous outcomes. We employed a number of different evidence-based practices in addition to Housing First, Pathways Case Management being another, and now we're beginning to see measurements that we're able to go back to the funders to show outcomes of people that we've moved off the streets into housing. At the last numbers I looked at, around 98% of the people that we had moved off the streets, many of them very chronically homeless, who have not returned to the streets, again preventing them from becoming homeless once again. And so, again, that just adds to the funders talk about that. In many, many communities, you've got what's called a funders roundtable, and these funders all talk to each other. Again, I'm talking private funders. But again, now we're starting to leverage public money through SAMHSA and our grants, the CABI grants, as they call them, to be able to work in a collaborative way to benefit homeless individuals. So there are ways that you can do that, and it's highly important, and I know Daylene talked about that too.
This is Daylene. I think, just if I could just add to this, I think one of the first things that needs to happen is we need to sit down and talk to one another. We talked about the coalition model, and that's one of the strengths, because as a coalition we can convene people and start the conversations. In my community, we have a large number of organizations that all sit around the same table, and we agree to collaboratively invest in evaluation. We talk about, as a large group, what are the best measures, how we're going to be able to have enough capacity collectively to be able to engage in some good measurement. And we also talk about how to have feedback loops so that the information that we learn from these evaluation tools and processes can allow us to course correct rather than just grade ourselves at the end of a project.
Yeah, and I'd add to that, again, getting everybody around that table talking, and sometimes that talking emerges into arguing. And right now, for example, we're embroiled in a very heated discussion around our A Way Home for Tulsa collaborative around the use of an evidence-based tool, whether to use that or not. And many of us are arguing that we absolutely must use an evidence-based tool, and others are arguing, no, we don't need to do that. What we have is good enough. But that's a part of the sausage making, as I like to call it, being able to get things done at the community-based level for large system change. And so if we're going to change and move the needles in towards some of these more preventative areas, we can't be afraid to have some arguments with each other if that's what it gets down to.
Thank you so much, Mike and Daylene. We're going to take one more question since we're running a little bit over, and I'm going to combine a couple of themes that have been running through our questions. People had asked, describing a little bit about what some of the models that we saw earlier, especially in Sarah's presentation, and people have also asked about prevention mostly being focused on adolescents or adults, as in the case of Mike's program. And so people were wondering about focusing on the earlier years. So if somebody would like to speak about focusing on the earlier years, I think it may also address the models. Sarah, would you like to get that one?
Sure. One of the, I didn't mention it in my quick run through of the funding mechanisms, but one of the individual interventions that has demonstrated a lot of impact, both on families as well as on government systems and funds, coffers, is a nurse-family partnership, which is a home visitation program that works with low-income, first-time mothers to promote positive attachment between mother and baby, actually starting with prenatal care, and then positive attachment, good parenting practices. And it has a myriad of effects to both the mother and the child in academic achievement, later criminal justice involvement or juvenile justice involvement, and to the mother in delaying a second child and reducing child welfare involvement and other issues. So that program, there are grant funds, there are block grants from the HRSA's Maternal and Child Health Agency section that goes to that, and then it also has been looked at by public and private insurance as a way of promoting health of families more broadly and getting kids a good start in life. And that is a program that I think we consider, I have considered myself a behavioral health advocate person, but I think maternal child health folks who don't necessarily consider themselves mental health or substance use advocates or policy people, they embrace those early years and considering how we can get babies and children a good start. So that's one model that has various different funding sources. There's also actually foundations that have funded it as well, especially demonstration programs. So there's lots of different pathways, as we were trying to demonstrate. There's lots of different funding sources that can contribute to specific interventions, and then there's also different sectors that claim those interventions, and the impacts then are in all sorts of other sectors that need to be measured and then need to be reinvested back into the community or back into the population. I hope that was helpful.
Thank you so much, Sarah, and thank you again to all of our presenters, to Fran for offering us such a lovely introduction, and to SAMHSA for its support, for Sarah Stieberman and David Shern for their presentations, to Max Crowley, Daleen Dutton, and Mike Brose. Again, we will have the webinar recorded, and that will be on the MHA website within 2 weeks. The slides will also be available for download, and I'll be very happy to ask our presenters if they can put up perhaps a little bibliography that will give more information about the specific programs and funding sources that they mentioned. So
Debbie,
again, thank you all. Yes, certainly, David.
Yeah, just real quickly, just to remind people that there is a paper that goes with this presentation that provides all of the bibliographic material and presents more information on funding and implementation. That will also be posted on the MHA website.
Thank you, David. That answers most of the questions that we had. How do folks get more specifics? So again, thank you all, and we look forward to people joining us for the next set of webinars.